Order. Call this meeting to order. This is the Standing Committee on Health. This is the Standing Committee on Health. I'm John M. MacDonald, MLA for Hants East and the chair of the committee. Today we will hear from the Nova Scotia Healthcare Program, the Nova Scotia Health Cancer Care Program and Nova Scotia Breast Screening Program regarding cancer screening programs. Just a reminder to put your phones on silent. I'll now ask the committee members to introduce themselves by stating their name and the constituency, and I will start with MLA LeBlanc.
Hello, everyone, and good afternoon. My name is Susan LeBlanc, MLA for Dartmouth North.
Hi, I'm Lisa Lachance. I'm the MLA for Halifax Civil Sable Island.
Good afternoon and welcome. I'm Rafa Di Costanzo, the MLA for Clayton Park West.
Hello, my name is Kelly Regan. I'm the MLA for Bedford Basin.
Good afternoon. My name is Danielle Barcos, and I am the MLA for Chester St. Margaret's.
Good afternoon, and welcome to everyone. I'm Chris Palmer, MLA for Kings West.
Good afternoon. I'm John White. I'm the MLA for Glace-Bain Dominion.
Hi, Nolan Young, MLA for Shelburne.
Thank you. For the purpose of Hansard, I'll also recognize the presence of Legislative Counsel Gordon Hebb to my left and Legislative Committee Clerk Judy Kavanaugh to my right. So what we'll do first is we'll allow everybody to introduce themselves and their position, and then we'll go to opening remarks. And I will start with my far left, Mr. Stewart.
Mike Stewart. I'm a gastroenterologist and endoscopist, and I'm the medical director of the Colon Cancer Prevention Program.
Hi, everyone. I'm Eileen Kilfoil. I'm the manager of the 3 cancer screening programs at Nova Scotia Health, so our colon, cervical, and lung programs.
Hi there, I'm Krista Rigby. I'm the Director of Population Oncology with the Nova Scotia Health Cancer Care Program. So I work closely with Eileen for our 3 screening programs, as well as health promotion and cancer prevention.
Rob Grimshaw, I'm a gynecologic oncologist, colposcopist, and medical director for the cervical cancer screening program.
Good afternoon, everyone. My name is Helmut Hollenhorst. I'm a radiation oncologist and the senior medical director of the Provincial Cancer Care Program, co-leading with Jill Flynn, who sends her regrets for today.
Hi, I'm Dr. Siân Iles. I'm a radiologist specializing in breast imaging, and I'm the medical advisor for the Nova Scotia Breast Screening Program.
Good afternoon. I'm Trena, Metcalfe, Program Manager for Nova Scotia Breast Screening Program.
Hello, everyone. I'm Ann Yuill. I'm Director of Healthy Populations and Provincial Initiatives with the IWK, and the breast screening program is in my portfolio.
Thank you. And reading glasses, so apologize, Dr. Stewart. It was fuzzy because I'm wearing reading glasses. So the next is opening comments. So how many people have opening comments? Okay, so I will start with Dr. Hollenhorst? Dr. Hollenhorst.
Thank you very much. Good afternoon, and thank you for the invitation to meet with members of the Standing Committee on Health. As Senior Medical Director of the Provincial Cancer Care Program, I have the honor to co-leading an incredible, dedicated and talented multidisciplinary team of cancer health professionals and administrators with my colleague Jill Flynn, who wasn't able to make it to today's meeting. Together with our leadership team, we are responsible for developing and delivering adult cancer care programs and services across the province. This includes cancer prevention and early detection, treatment, follow-up, supportive care, palliative care, and end-of-life care, as well as we are working closely with our partners at the IWK Health Center, who have responsibility for pediatric cancer and the breast screening program. Our work is guided by our cancer control strategy, which was informed by cancer care teams, patient families, and communities. And we are currently in the 4th year out of 5 executing a strategy that was mainly focused on cancer care stabilization and optimization. This is also aligned with the Action for Health. Since today's discussion is about cancer screening, I'll provide you with a brief overview of cancer screening in Nova Scotia. Cancer screening is not for people who have possible symptoms of cancer. These individuals need to see a healthcare provider. Cancer screening is about looking for cancer or pre-cancer before there are warning signs or symptoms. To be effective, screening must be done regularly at the interval recommended by a specific cancer screening program in order to be effective. Nova Scotians are fortunate to have 4 organized cancer screening programs: cervical, colon, breast, and our newest program, lung cancer screening. Of these, cervical, colon, and breast are population-based screening programs, targeting individuals with a certain age group who are at an average risk for a specific cancer. Lung screening, by contrast, targets individuals who are at high risk for the disease because of evidence indicating that lung screening is only beneficial for those at high risk. In fact, all cancer screening programs in Nova Scotia are based on the latest scientific evidence and leading practice. The development of clinical screening guidelines include literature review and discussion with subject matter experts, a review of leading clinical practice and guidelines from across the country and beyond, and a review of the Canadian Task Force on Preventative Healthcare Guidelines. The evidence is monitored, and as new evidence becomes available, guidelines are reviewed, discussed, updated as appropriate. The goal of cancer screening is to prevent cancer when possible or find it early when treatment is more effective and cure is more likely. Cervical and colon screening programs can prevent cancer, whereas lung and breast screening can find cancer at an earlier stage. Our screening programs are designed to lift the administrative burden of cancer screening from primary care providers to provide equitable access to cancer screening for all. This includes not needing a primary care provider to access our programs. Colon cancer home screening kits are mailed to all Nova Scotians every 2 years, beginning at age 50 until they are 75. Those who have an abnormal test results get a letter in the mail, copied to their family care provider if they have one. A screening nurse navigator also reaches out to answer questions about the recommended follow-up screening colonoscopy, and if the person agrees, books the test. Those with a normal test receive a letter indicating the test is normal and that they should do the test again 2 years later when it comes back in their mail. Pap tests for cervical cancer screening are available at Well Women clinics across the province. A move to HPV testing is next. And in a couple of years, it's likely Nova Scotians will have access to at-home tests for cervical cancer screening. We are already starting the work on this. Our lung screening program targets Nova Scotians between 50 and 74 with 20 or more years of current or former daily smoking. These people can self-refer by phoning the lung screening program to book an appointment. During the telephone appointment, a screening navigator provides information about lung health, offer tobacco cessation supports for current smokers who are interested in quitting, and conduct a clinical assessment to determine if they would benefit from a chest CT. Those determined to benefit from the chest CT are offered one. If they agree, they are booked for the test. Their test results is mailed back to them, along with when they should have another scan. Those with an abnormal test results receive a phone call from the nurse navigator who answers questions and provides information on next steps. The lung screening program was introduced in Central Zone in January of this year. It will be expanded to Eastern Zone in fall and to the rest of the province in 2025. People can also self-refer to breast screening program. I leave this to Dr. Iles to share in details of how her program works. You may wonder if cancer screening program work. The answer is resounding yes. Our cancer screening programs are saving lives. Incidence of cervical cancer has plummeted as a result of screening, and with vaccination we can eliminate cervical cancer altogether. In 2023, over 1,000 Nova Scotians had colon cancer prevented. They had no warning signs. They did the home screening test. Precancers were found and removed because of the colon cancer home screening test. In the few short months since the lung screening program has been operational, 3 individuals have had early lung cancers identified and recovering from their surgery. 4 are in the middle of workup. 2 of them did in fact not have cancer, and 1 patient unfortunately passed away for other reasons unrelated to cancer. Cancer screening programs are an excellent use of healthcare resources. We are saving lives, and we could save many more if more people were regularly screened. We know we have more work to do. We are moving towards having nurse navigators for all people who have abnormal screening tests to ensure they get the information and follow-up care they need. We are working with diverse communities to co-design information and ensure a cultural, sensitive approach and experience to cancer screening and all cancer programs and services. And on the horizon, Cancer Screening Nova Scotia, a one-stop shop for cancer screening and accelerated workup for suspected cancer, will be a priority for our renewed and next phase of cancer control strategy. More to come. Stay tuned. Thank you very much.
Thank you. Dr. Iles.
Thank you. I'm Dr. Siân Iles, as I've said, and I'm the medical advisor for the Nova Scotia breast screening program. I'm a radiologist, which means I'm specialized in imaging, and I subspecialized in breast imaging. I've been part of the Nova Scotia breast screening program since 1991. I think I'm the only one left who was with the program from the very, very beginning, and it's been a privilege and a lifelong joy to really be part of this. I'm joined today by my colleagues Ann Yuill, who's the Director for Healthy Populations and Provincial Initiatives from IWK Health. Her portfolio includes our program, and Trena Metcalfe, who's our manager for the Nova Scotia breast screening program. I want to begin my remarks by emphasizing the importance of screening mammography. Breast cancer is the most common cancer in women in Nova Scotia. Early detection by screening mammography, which can find cancers much smaller than those detected by clinical symptoms, leads to reduction in breast cancer mortality, fewer years of life lost due to breast cancer, and decreased morbidity of breast cancer treatment. Screening mammography is the only test to date that has been shown to decrease mortality from breast cancer. I'm pleased to share that Nova Scotia has one of the most robust and successful breast screening programs in the country, with unique features and capabilities. Nova Scotia launched its organized breast screening program in 1991, starting with one single clinic in the Halifax Shopping Centre. I used to drive out there and read the images. We had to go in person. Since then, it has expanded to 11 fully accredited fixed sites throughout the province. A mobile screening program began in 1994 to better reach rural communities and priority populations to ensure equitable access to screening across the province. Today, the mobile screening program services 30 communities across Nova Scotia. In 2022, 56,951 screening mammograms were performed. 3,986 were abnormal and required further testing. 1,305 went on to have a needle core biopsy, and 366 cancers were diagnosed as a result of screening. Self-referral for screening mammography begins at age 40 in Nova Scotia. We're fortunate in that regard. No primary care provider is required to refer or to be moved through the clinical pathway if additional testing is required. Self-referrals can be made through calling one central toll-free number. As Helmut said, screening is for individuals who do not have signs or symptoms of breast cancer and who have not had a previous diagnosis of breast cancer. Individuals with symptoms are not eligible for screening. They should be evaluated by a healthcare professional and referred for diagnostic breast imaging for further evaluation. Screening mammography is a standardized set of 4 breast images performed at a screening site and interpreted later by screening breast radiologists. Diagnostic breast imaging is performed at a diagnostic site and targeted and tailored to evaluate a clinical sign or symptom or to evaluate an abnormality already seen on a screening mammogram. Maintaining capacity in the diagnostic sector is crucial to an effective program. Nova Scotia is the only province to have central intake and booking of breast imaging appointments, and that's all appointments, not just screening. Our unique Provincial Breast Information System supports real-time monitoring and evaluation of wait times, maximizes use of available diagnostic breast imaging appointments, and allows for appropriate booking of procedures. Province-wide standardized synoptic reporting in the breast information system allows proactive booking based on radiologists' recommendations, which takes the burden off primary care and supports access for patients not attached to a primary care provider. The breast information system also tracks the entire journey of a person through breast imaging, whether screening or diagnostic, up to the point of definitive surgery for breast cancer, with safety checks in place to ensure that people are not lost to follow-up and that they get care in a timely manner. I would like now to highlight some of the unique features and strengths of our program. The Nova Scotia Breast Screening Program was the first program to have a patient navigator. The patient navigator tracks a person's journey to ensure follow-up occurs, as well as being a resource for patients, primary care providers, and the public with any questions they may have about breast screening. Nova Scotia does not have opportunistic screening. Opportunistic screening is a screening test performed outside of an organized program. Examples include mammography, breast ultrasound, or MRI done at private clinics, as may occur in other provinces. These test results and patient outcomes are not tracked or monitored by a screening program. This core function ensures that a program is meeting quality indicators and will achieve the desired results of decreased mortality. We have no private clinics that provide breast imaging in Nova Scotia. All screening and diagnostic breast imaging services are provided within the public system and are overseen by the Nova Scotia Breast Screening Program, and all data from these services are captured and monitored. Our program is truly population-based. Nova Scotia was the second province to implement density notification in all screening results letters in October 2019. It was the first province to use automated software for standardized calculation of breast density, using software developed here in Nova Scotia. This company developed because of initiatives by the Nova Scotia Breast Screening Program to try to standardize assessment of breast density, and their software is now used worldwide. We have now implemented automatic annual recall of all women who have a screening mammogram with category D density through our breast information system. We are nearing the completion of province-wide implementation of quality software, also developed by this company, that provides standardized image quality evaluation, which will be used to monitor and improve image quality, a crucial factor for high-quality screening. Nova Scotia has evidence-based average risk clinical practice guidelines that include eligibility for trans and gender diverse individuals. Anyone who meets these criteria may self-refer for screening from the age of 40. Nova Scotia is one of only 2 provinces that has an organized high-risk screening program following the model in Ontario. Anyone who has a breast cancer risk assessment using a recognized clinical model and has a lifetime risk of greater than 25% is eligible for this program, which includes annual screening MRI as well as mammography, starting at age 30. The Nova Scotia Breast Screening Program provides quality monitoring for the entire system, including wait time reports, annual reports, national reporting on quality indicators, and indicator reports for female communities in the province. We are connected with our sister breast screening programs across Canada through the Canadian Partnership Against Cancer, which allows provinces and territories to share evidence and practice and reports on mammography screening programs nationally. In closing, I want to emphasize the importance for individuals to self-refer for screening beginning at age 40 and to continue receiving regular screening. Screening programs will only make a substantial difference to population health if enough of the eligible population uses them. I look forward to answering any questions the committee may have. Thank you.
Thank you. So we'll start with the questionnaire answer period, and it'll be 20 minutes per each caucus. And then roughly we'll divvy it up after that, and it'll be about 6 or 7 minutes. So the first will be 20 minutes to the Liberal, MLA Di Costanzo.
Thank you, Chair, and thank you all for being here. I've been looking forward to this, so I hope I can do it justice, but I want to thank you and especially thank Dr. Iles for being here. I have wanted to meet with her personally since my diagnosis of cancer and what I've learned over the year and a half, and I haven't had the opportunity, so I'm grateful that she is here. I'm also really grateful to see the support from so many women who have reached out to me since my diagnosis, since I've been speaking about what my story and what has happened to me and learned about what dense breasts actually mean. And they are here, and I honestly, you're going to hear my story, but my story is very small compared to a lot of them. There are many much worse situations. I was the lucky one. So my story goes is my mother had cancer, breast cancer, at age 72. She lives in Ontario. And all I remember, actually, it was not a big deal because she had a lumpectomy and radiation. It was bad, but I was living in Halifax, so my sister and brother took her. But it wasn't as big a deal as it has been for me, which I've had it 10 years later, which things should have improved for me instead of gotten worse for me. So because of my mother having cancer, at age 50, I started having regular mammogram, yearly mammogram at the Halifax Shopping Centre. Every year, regular, always negative. Until 2022, when I had just turned 60, I was the most active 60-year-old, in my opinion, cycling 67 kilometers and doing everything, working 150%, loving every minute of it, and had all the energy in the world. And I was given, so there was a little lump. I go see the doctor. I actually took it easy because it was small. And she says, okay, I'll send you. I was sent to the IWK for the 3D mammogram and ultrasound, and I was given the clear. Everything was great. My husband surprised me for a lovely trip to Greece that year to celebrate my 60th birthday. I had cancer, but nobody told me. 6 months later, I have another lump on the same breast. On the same breast, a little above and a little harder this time. I took my time because, it's the same breast, I'm sure it's negative. It took me 3 months. By the time I got my next one, I was getting dressed, putting my boots to go speak on March 6, 2023, to go speak at International Women's Day. My family doctor called me and said, Rafa, we need to send you to a biopsy because you have a 95% chance of malignancy from the mammogram that I just had only 6 months or 8 months later. I was shocked. I just said, I joked with him and I said, I need to go speak. This is not a good time. I'll think about it. And I went, I did my speech, came home, and life has changed night and day since that day. Since that day. My story is nothing compared to a lot of the women who are here today. So my life has been, then it was one appointment after the other, one delay after the other, whether it was the biopsy, whether it was the other. And I was lucky that my mastectomy was brought forward because somebody canceled. So I had mastectomy. Then I didn't even know that now my tissue is being sent to California, which is a good thing. I didn't ask for it. And now I scored 30 in an Oncology test. I had no clue what these are, what the test stands for. Now I have a high risk, and I was told a week before I'm supposed to start my chemo that I need at least 4 rounds of chemo to be sure. That was the worst day of my life. Chemo has been, I have had fear of chemo, and rightfully so. Chemo has done so much damage to me, to my life, to my work, to my family, and to everybody. And many of the women here have suffered the same. My cancer should have been found they tell me cancer takes 3 to 4 years to develop. So I've had my mammograms in 2020, 21, 22, and in 22 I had not only a mammogram but an ultrasound, and it wasn't found. Then I heard about dense breast and started to be educated. I wish in 2022 I knew the high risk that I was under. And I found out that it was us, when we were in government, that we brought in this amazing software that Dr. Siân Iles just talked about. So we tell women, you have a higher risk of developing cancer, you have a much lower, 50% or 43% chance your mammogram will miss your cancer. But if I want it, and many women here have gone to their family doctor and asked for extra screening, and the doctor tells them, you will be denied. You will be denied any extra screening to see if we can find the cancer early. This is just beyond anyone's imagination, that women want to find it early, and we're telling them, no, you can't. Let's wait until you're in stage 2, 3, 4, and then we can give you chemotherapy that costs money. So I went from, probably just a lumpectomy and radiation, $40,000, $50,000, to minimum $200,000 to the cost to the taxpayer. And I have another surgery maybe coming as well. So all this cost could have been saved, but most importantly, my life, my quality of life has changed for I don't know how long. It's been over 6 months since my chemo. I'm still not back, and a lot of side effects that I've had to deal with. What's important to me, I know Dr. Siân Iles just in her speech said, we have the most robust and successful breast screening program in the country. So how did I go for 10 years of mammograms and in 22, an ultrasound and a mammogram, and it was missed, and then I ended up with severe treatments. So explain, and honestly, there's at least 20 women here listening to you today who've gone through this, and some of them are in stage 4 and 5. So how can this robust, amazing treatment fail women with dense breast? Do you agree that dense breast is a high risk, as you're sending it in the envelopes with our screening, telling us you have high risk, but you're not allowed to have any extra screening? How do you explain that to me and to the others, please?
Dr. Iles, I forgot to mention, wait till I get your mic so it's on the record. Dr. Iles.
Thank you, Rafa, for telling your story, and I am so sorry for what you've been through. It is really terrible to hear this story, and I'm very sorry to hear the stories of all the women here as well. This is what I've spent my life doing, is trying to prevent that kind of story. Unfortunately, screening is not perfect. As you pointed out, in the denser breasts, we're not as sensitive. Breast density, as far as being high risk in and of itself, Rafa, it doesn't confer high risk in the sense of the genetic kind of high risk that we talk about with the BRCA mutations. The risk is higher in women with dense breasts. What the problem is, as you have pointed out, is we can't always see the cancer as well with a mammogram, right? So if you're looking at a regular woman with a fatty breast, our sensitivity is about 80 to 90%. In someone with more dense breasts, as you've pointed out, the sensitivity is about 60 to 70%. What we're doing, however, is a population-based program, right? So we have to be able to provide a test that is readily available, that is accessible, that is equitable, and that has proven benefits. And that's where screening mammography comes in. As you've pointed out, the benefits may not be equal for everybody, and some people with dense breasts, we're not as sensitive. But we may miss cancers in any other breast as well. Unfortunately, it's not a perfect test.
MLA Di Costanzo.
Unfortunately, that is just not good enough when you are telling me that you know dense breast is higher risk and you're missing it. And you can do, and other provinces have. BC have gone up and trained their technologist, on mammogram technologist, on an advanced computer software that's called Contrast Enhance. Both abbreviated MRI and contrast enhanced mammography, abbreviated is used in Ontario, contrast enhanced is used in BC, find 4 times what we're finding here. So these 15%, because we're finding 5 in 1,000, the other 15 are these women who have gone through hell and back. And we know we can catch it early. We do. And we can, because they are doing it. Your colleagues at the same level have found ways. And I would love for you to tell me what you are doing to reach that same standard. I have a sister in Ontario who got an abbreviated MRI because her sister, which is me, had cancer, and I cannot get it for my healthy breast, but my sister in Ontario gets it because I had cancer. Explain that to me.
Dr. Iles. No worries, we do it, trust me.
I'm on, yes. Rafa, I want to explain something. Our high-risk program...
Point of order, sorry. MLA Regan.
Dr. Iles, her name is MLA DiCostanzo.
Oh,
right?
sorry.
This is a formal proceeding.
Yeah, sorry.
Right? I appreciate you probably do that when you're dealing with patients, but this is a formal proceeding, and her name is MLA DiCostanzo. Thank you.
Just that. So what happens is the mic goes off because only one person's allowed to speak. Thank you, MLA Regan. I should have caught that. Dr. Iles.
Well, we do have a high-risk program, Rafa, and what I encourage anybody to do is to have a risk assessment. And if you go to our website, there are actually some guidance on how to have a risk assessment done. And if you have had a previous diagnosis of breast cancer and you meet our high-risk criteria, you are eligible for high-risk MRI screening. So that's the important component to know. If you've had the diagnosis of breast cancer, or even if you have not, make sure you get a risk assessment because we do have a high-risk program.
MLA DiCostanzo.
Please explain to all of us what is high risk, because my mother had cancer, I have had cancer, and I'm refused to have it. So what is considered high risk?
Dr. Iles.
And
oh, sorry. MLA DiCostanzo. I'll let you finish so it's on the record. You good?
I'm sorry, yes. There are 3 things, and I know I can't have it. And many women, and I will reach another point that you said in your things after you answer that one, please.
Dr. Iles.
Well, there are recognized risk models that are used to estimate breast cancer risk. Some of the things we know contribute to high risk are, for example, genetic mutations. Women who've had mediastinal irradiation when they were younger, those are also considered to be at high risk, and they would be included in our high risk program. The risk models that we recommend are the IBIS and the CAN-RISK models, and both of those include breast density as one of the risk factors. So that is kind of where we go, is using the recognized risk models, which do establish pretty accurately who is at highest risk, and that's who we can offer the high-risk screening program to.
MLA DiCostanzo.
I didn't hear, for me having cancer puts me at a higher risk. We know many women who've had cancer in one breast, it reoccurs in the second. But you're telling me, no, wait until you have another lump until you're in stage 2 to 4, okay? Until I feel the lump, either myself or through a doctor, before I will be qualified for an MRI. Is this even conceivable to most women who are sitting here? Wait until you're stage 3 and 4 before you're allowed to have an MRI. You've had cancer, breast cancer, and you're not allowed to have an abbreviated MRI.
Dr. Iles. No worries.
I'd just like to point out that we're really kind of beyond the screening discussion here. We're really now in a discussion about something called surveillance. Once you've had the diagnosis of breast cancer, then we're talking about surveillance, not primary screening for asymptomatic women. As I said, we do have accommodation for high-risk women to be continued in the high-risk surveillance program, and we do have to depend on the risk models. Average risk is about 13%. intermediate risk is 13 to say 20%, and high risk is 20% and above. We say 25% in our guidelines. We actually do accept 20%. There has to be a point at which we can make people eligible and people not eligible. Otherwise, we just would be overwhelmed with the needs.
MLA DiCostanzo.
I will come back about the overwhelmed and the need, and that's something in your speech, but there's also another word that you spoke about in your speech, in your opening remarks. It's called Nova Scotia does not have opportunistic screening. I learned about dense breast because one of the patients who are here who spoke on the radio back in October. I was going through chemo. I didn't even know about my risks of dense breast and that after cancer I will not be allowed to have an MRI as a regular. And she went on the radio to say, I go to Ontario to get an extra ultrasound. And I thought, what? That doesn't make sense. She's had a mastectomy. She's had a story like mine, if not worse. And she's still denied to have an MRI here. And you're calling her and me. I wish in 2022, when my husband took me to Greece, I would have spent $200 to get an MRI and save this government and this taxpayer $200,000 of treatment and the hell that I went through. It was wrong. It was wrong what we're doing here. We're waiting till people need chemotherapy before we treat them. And these women need a voice. And other provinces have seen this. And they're not waiting for us to die to base it on mortality. That's what we're doing. We're basing everything on mortality. You want me to die to be a statistics? Then we'll increase the numbers for you so you can give me MRI. No, this is wrong. Wrong. I don't want their daughters to go through what I went. And I will speak till I die. Until this is changed, Dr. Iles. And I love you, because I've heard truly, my family doctor knows you and thinks the world of you. The radiologist that did my mammogram loves you, and you are a wonderful woman. You are stuck on something that doesn't make sense. And this policy that we're doing is causing a lot of harm to women. And we can do something about it, just like Dr. Gordon did, just like Ontario did. And my sister should not be allowed to have the MRI above me. It's wrong. Okay, please.
Okay, well, order. Just to be clear, okay, one person is speaking. If the gallery interrupts or does it, the gallery will be asked to leave. So I understand what we're at, but no, MLA DiCostanzo, you're fine. I just wanted to let everybody know that no commenting from the gallery. MLA DiCostanzo, yeah, you have 2.5 minutes.
That's it? Okay. So the word opportunistic, it is wrong. To call me opportunistic, I wish I was smart enough to have the MRI for the $200 in Greece. I wish, and I will, go to Toronto until the policy of Nova Scotia changes, because I'm not waiting till it be stage 2 or 4 before I catch it. That's what you're offering me in Nova Scotia under our policies. These policies have to change before more women and more younger women. I had it in my 60s. I can't imagine what it does to a 40-year-old. Losing your breast, losing your hair, losing your identity as a woman, literally. And I can handle it at age 60. It's much harder. It breaks families. It breaks so much. And wrong. We are doing it wrong. And it doesn't even make economic sense what we're doing. We can save money and we can help women. And it's wrong what we're doing to us. So opportunistic, please take that word away. They are lucky to have opportunities to go and pay for it. And we need, if you don't want us to have the private, offer it to us. Nobody will go. Why would I go and have it somewhere else if it's offered to me here? Why would I? Why would Elizabeth, who spoke on the radio, does a trip every year at her own cost? We can't do this to women. We are discriminating. And talk about discrimination, I also heard that it's much higher in black women and multicultural women. I've never even spoken about this. right? And most of the women are here are white, and that's high in the white. So imagine how much higher it is in the other population, but they don't speak up. I'm their voice. Let's help them.
Emily DiCostanzo with 32 seconds.
All right. What's the question that I would go back actually and just ask one thing later. Kelly, do you have anything, or how much time do I have?
Well, now you have 19 seconds. 18.
Okay. I thank you, all of you, truly, and please do right by women. It is your daughters that I'm speaking for. I have 2 daughters. I'm not going to let them go through this. Never. Hopefully never. When we are lucky as women to have organs on the outside that can be tested easily.
Thank you. Next will be the NDP for 20 minutes. MLA LeBlanc.
Thank you very much, Mr. Chair. I'm just going to ask a couple more questions about breast cancer screening and dense breasts. Dr. Iles, in the fall you mentioned in an interview, and you've sort of talked about it here today, that we need to collect more evidence to gauge the value of the supplementary screening for individuals with dense breasts before we can put public money towards it. So can you elaborate on the type of evidence that would be needed and yeah, like what would indicate for you a change in policy, or what would prompt a change in policy?
Dr. Iles.
Thank you. That's a great question. I think if we look around the world and even across Canada, there's a great variation in interpretation of evidence and guidelines. The same evidence is used, and different guidelines come from the States, from Canada, from Europe, all based on the same evidence. When it comes to dense breasts, the evidence is mainly around the category D, which is the most dense breast. To reassure women in Nova Scotia, the average percentage of women in all age groups with dense breasts is 2%. Okay? So I want to encourage people to come to screening. Don't worry if you have dense breasts. We're not as good, but please come to screening anyway, because the vast majority of people do not have category D dense breasts. The category D dense breast, there is some evolving evidence, and it was published here in Canada by Dr. Jean Seeley, who's a colleague of mine, and I know you all know Jean. She's a wonderful human and very interested in this dense breast advocacy. And what she was able to show is that in provinces that have provided annual screening for dense breasts, for breasts, they didn't always have the breast density as part of the information, but it was basically looking at that particular issue, that we decreased something called interval cancers. So in a screening program, an interval cancer is a cancer that occurs between screens, something like Rafa is talking about here. You have a negative screen, and then you're diagnosed with the cancer later. Unfortunately, it's a real problem in all screening programs, no matter how good they are, and it's one of the things we monitor as part of our program. And we evaluate all of our interval cancers on an annual basis to see, what happened. Was there something that could have been different? Was this true interval cancer? Lots of information that we gleaned from that. And we were able to, and this study did show that there was a decreased rate of interval cancers with annual screening. So we implemented our program, the annual recall, based on that data and other data that we have for category D. When it comes to supplemental.
So just 1 second, and I'm pausing your time for this one, by the way. Dr. Iles, just a reminder, so please refer to everyone as MLA in their last name. It's the same reason as why it's Dr. Iles. So just.
Thank you.
And MLA LeBlanc.
Yeah, so I thought the chair was going to explain that sometimes we might interrupt just to ask for clarification, and now I can't quite remember what the clarification was, but I think it was, so in Nova Scotia, if you have category D dense breasts, you can get a mammogram every year no matter how old you are. Great. Sorry, continue.
Dr. Iles.
When it comes to some of the other modalities for supplemental screening, the evidence is not as strong in the sense that we don't have enough evidence. We have some evidence. So we do know that, for example, supplementary ultrasound, contrast-enhanced mammography, abbreviated MRI, all find more cancers. But to establish a population-based program, there are other features, other factors that have to be taken into account. So if you look at the World Health Organization and the principles they use to establish a population-based intervention, then we're not at that standard of evidence yet for supplemental screening for dense breasts.
Emily LeBlanc.
Thanks. Okay, that's helpful. So, just real yes or no question. Can you confirm whether that data is being collected in Nova Scotia right now, like the data that you would need, or are you looking at larger population data, or are you looking at Nova Scotia data?
Dr. Iles.
No, we're really looking at randomized, well, there will be no randomized controlled trials most likely. What we're looking at is more evidence that interval cancers are decreased, and also that the screening is always a balance of benefits and harms. And harms are things like a false positive, having a biopsy you don't need. There's a concept called overdiagnosis, which is a real thing, which is that some of the cancers we find may never have become clinically evident during the woman's lifetime. And we are now putting her through treatment that she may not have needed. But we diagnosed a breast cancer in a screening program. So that and a number of other factors, including the environment that you're providing the screening program in, are very important in deciding whether to implement a population-based program. And that really has not been a consensus yet anywhere in the world.
Emily LeBlanc.
Thanks. And one of the other things I've heard a lot about in this discussion is the idea that when we're looking at, whether to implement a program or not, we look at the result being like life or death. Like, is it like, do people die from it? And it does seem to not make sense to, not have a program because not enough people are dying, where as opposed to a program or a situation where people might not die, but they're going to be a lot sicker and they're going to have a lot more treatment and they're going to lose their hair and all of the things that my colleague has pointed out. So can you speak, basically, also, I know that we, one of our jobs as MLAs in government is to manage money. So I want to know, can you speak in terms of, when you're looking at your end results, are you looking at numbers like lives saved, or are you looking at, what do you say? How great your life is, or how bad your life is, whatever that is called. And also, can you talk about has there been a lot of work done on the examination of a budget? Like, how much would it actually cost to provide extra screening for people, at least even with D breasts, but C and D breasts? So have those things been studied?
Dr. Iles.
Thank you for the question. We are really, at the moment, focused on our high-risk program. We want to ensure that those women at highest risk of breast cancer are getting good care. So that is, at the moment, our focus. That doesn't mean that we're not monitoring and looking at the numbers of women who have Category D breasts. Just to clarify, pretty much all of the evidence for supplemental screening is in Category D rather than Category C. Category C, we have about 25% of our population, Category C. 23% and 2% Category D. So if you know that we do 56,000 or more screens every year, you're looking at a quarter of those women requiring supplemental screening if we include Category C and Category D. So that'll give you some idea of the scope of what would be needed if we were to implement a supplemental screening program.
Emily LeBlanc.
Great. So with the 30 mobile screening locations, I'm sort of moving away a little bit now, and just in general, the screening program included in Nova Scotia Breast Screening Program, can you tell us how often screening appointments are offered? So, with the mobile ones, how often would someone in a community that gets a mobile clinic, how often would they have the ability to book an appointment? How does that work? I'll ask that first.
Dr. Iles.
Thank you, Emily LeBlanc. That's a great question. When we designed the stops for the mobile unit, we used a principle called geomatics, where we looked at the geographic distribution of women by age and postal code across Nova Scotia, and we then designed the stops so that ideally each woman can have the screening mammogram at the appropriate interval. So the intervals we recommend are age 40 to 49. We recommend annual screening, and we're one of the few programs that's able to do that. 50 to 60 to 74. If you're average risk, if you don't have a family history of a breast biopsy with atypical changes, then we recommend every 2 years. And that's how these stops are designed, to try to allow people to have access. We also place priorities, as MLA de Constanza pointed out, on the Native population, the other underserved populations. That is also a focus that we are quite interested in, and we're doing a lot of work in that area as well to try to ensure, as MLA de Constanza points out, that some of these other women who don't have equitable access to screening have a better opportunity. And I would like to talk about the concept of equitable access.
Oh, so MLA LeBlanc.
I would like you to talk about equitable access, but I have a lot of questions. But and I obviously I know how important it is, but I just want to ask you. So in terms of the way you've described that, like I get that, and you know I have just had a mammogram, but basically what happens with me, and I might talk about this if I have time when we talk about the colon cancer screening, is that I go, oh, I think maybe I'm due for a mammogram, and then I call, and then they're like, yeah, you should have one in 6 months, and so I'm like, okay, and then I book it now, because the fact is if I called in 6 months, I wouldn't be able to get one in 6 months, right? And so this goes to this, you know, how much we're being served by the screening. So I guess my question is, especially in the mobile areas, and I don't know why I'm pointing at my colleague across the way there, but I guess because he represents a town near Digby, are people able to get their appointments every year? Are people finding that they're calling, going, and they're saying, oh, well, we don't have one for a year and a half? So that's A part, and B part is, would you recommend that we have more breast screening available in general?
Dr. Iles.
Thank you. That's a great point. First of all, we only have about a 46% participation rate in Nova Scotia. We would like to have 70% minimum. So first point I want to make for everybody is come for your mammogram screening. That is our first line of defense. The more people come, the better. Population-based screening has been shown to decrease mortality in the screened population by 40%. The other very important point is if you come regularly, and you've pointed that out. Don't just come once and then assume it's good for 5 years. It's not. You need to come regularly. You need to come at the appointed time, as Dr. Hollenhorst pointed out. As far as the wait times, those are published, and Trena, I think, can talk about that.
That's okay.
Yeah.
Thank you.
Okay, MLA LeBlanc.
With respect. Great. Okay, I just want to say also, I wonder quickly, this pen is hilarious, by the way, and I enjoy this type of humor. Whoop, whoop, test your poop. When I turned 50 last fall, I got that kit in the mail, and I was like, what? This is amazing. It just gets mailed to you. It's amazing. I was shocked to know that only 42% uptake is in that program. So why wouldn't you do that kit? They mail it right to your door. Same thing. And I wonder if there's a way to send a letter when you turn 40 or whenever you do annual ones to say hey, now you're eligible. Come on in for the fun. Because it's way more fun to get a test like that than it is to have cancer. And I don't mean to joke about it, but honestly, I'm shocked at the what the numbers you've just given me. I don't know what we should do about it, but we should do something. But I did want to ask about. I want to change my tact a little bit to HPV testing. And so for exactly this reason that we're talking about. And Dr. Hollenhorst, you did speak about the fact that HPV testing is on the way. And I just wanted to get some clarification on some of what's been happening with that. We put out a press release today calling for the government to make sure that this program is implemented as soon as possible because it's saving lives, or will save lives. Can you talk about, you mentioned that it's maybe a couple of years away, but what has been done so far, and what are the barriers to making it happen tomorrow?
You want Dr. Grimshaw? Okay. So Dr. Grimshaw.
Question. Yeah, we're actively planning for the transition to HPV. There's a lot of reasons to do that. The first and sort of most pressing reason is that it's a better test to screen women who've been vaccinated through the school age program against cervical cancer. We know that the vaccine through the school age program will prevent, the one that was used will prevent 75% of cancers. The new one probably is closer to 98%. So as they age into screening, if they have an abnormal test, it's more likely to be false positive. They have to come in, see someone like me, have biopsies done, all sorts of things. So the HPV test is a better test to keep them out, in theory. The other reason is technologists that read pap smears are becoming thin on the ground. Schools have closed around Canada. There's only 2 that are still training people, and none of them are in the Maritimes. So the ability to attract people down here to sustain screening will pass. HPV screening is a little better than regular pap testing, much like breast testing, like colon screening. The main problem is people not having the test regularly, not taking advantage of the test that's available. Where we stand right now, we have an active planning process that's looking at the transition. It involves all sorts of things needing to be done. Right now, pap smears are done at 5 or 6 labs around the province. Under HPV testing, what happens? You get an HPV test done. If it's negative, you're good to go. And unlike pap testing, where it's every 3 years, HPV testing, if you're negative, is every 5 years. So that's a big benefit. If it's positive, they then take the same specimen and test it and do a pap test on the same specimen. And that determines whether you get a repeat test done in 6 months or a year, or if you come into colposcopy. So the number of pap tests in the province will go from around 55, 60,000, or whatever we're doing a year now, down to probably 3,000 or 4,000, which will only be in one center. So that has to be rationalized. The machines that are used to do the HPV testing need to be decided upon where they're going to be. The companies need to be chosen. So the process we figure is going to be about 2 years from now before the HPV testing rolls out. But it's coming.
MLA LeBlanc with 4 minutes, 10 seconds.
Okay, thank you for that. Do you have like any kind of ballpark price tag on sort of a yearly cost for that program when it comes?
Dr. Grimshaw.
Yeah, we have. And it's been submitted. The nuts and bolts part has been submitted through the lab business case, and we're just teasing that apart to see what pieces of that are covered and what are not. The other change for the program is we've talked about navigation, meaning having someone that contacts people with abnormal results and navigates them through the process of biopsies for breast, colonoscopy for colon. We're looking to transition cervical screening to the same standard as the rest of the programs in the province, a navigated thing, so that if you have a negative test, you'll be able to see your negative test and you know you're good for 5 years. If you have a positive test, you'll have a navigator contact you, tell you that the results are abnormal. Overall, there's a little extra cost with that. The overall pricing for HPV testing versus cytology is pretty much cost neutral. And will only probably get cheaper as time goes by, because lab tests tend to get cheaper, whereas humans reading cytology tend to get more expensive over time.
MLA LeBlanc, 3 minutes.
So other provinces use their cervical cancer screening programs to keep track of individuals who are due for a pap test, and letters are sent to patients to remind them. And, you know, again, I just referred to the colon cancer screening program that sends a thing in the mail. And I mentioned, wouldn't it be great if mammography program did, or the breast screening program did? Is that something you might look at in terms of HPV and breast cancer screening? I don't know who wants to answer that, but
Dr. Grimshaw?
For cervical screening, we have not done that. We've done some research projects on it. It does give a yield that's small. Going forward, though, I think we're pretty excited about some of the opportunities with apps and Your Health NS and things like that as a way to remind people of that they're due for a test. And certainly part of the navigated process that we're looking at is reminders. Again, the most important thing is getting the testing done. It's not. We know we're very good in the province. If a woman has a pap test, the women in the people in the province with cervixes are very good at following up. It's the people that aren't being tested regularly that are the problem.
MLA LeBlanc.
Well, that also speaks to the lack of primary care, attachment probably, because you're not going to go to a mobile clinic, for instance, to get a PAP if you don't have a primary care provider. Back in December, the executive director of Halifax Sexual Health Centre noted that they'd seen a rise in number of people coming in to get PAPs because also that when they do have a primary care provider, they're being told that they don't do PAPs anymore as part of their practice. So I'm just wondering, is anyone, any of you aware of the problem, and what actions are being taken to ensure that primary care patients receive, that the care that primary care patients receive includes necessary cancer screenings?
Okay, Dr. Grimshaw.
Sorry, absolutely right. We know, and I commend the sexual health clinics around the province. They have stepped up for women that don't have PAP tests, and I know that for me in the colposcopy clinic, 30 or 40% of the women I see do not have a nominal family doctor that's taking care of them. And they get their services provided usually through sexual health clinics around the province or through well women's clinics around the province, and they make all the difference. That's one of the things that's very appealing about the transition to HPV screening is, number one, we'll change the number of tests that are being done from every 3 years to every 5 years, so there'll be sort of more time available to do that. The other advantage of HPV testing is that it does offer an opportunity for self-testing for some patients, to have a self-test done that can work sort of like the colon test. You get a kit in the mail, you test it at home, you mail it in, and you get a result. And that way, for women who do not have an attachment and have a hard time getting in to see someone through a sexual health clinic, it gives them that option. That's partly why the navigated approach is so
Order. Sorry, I should have, at 20 minutes I say order and I have to cut you off. Apologize for that. PC Caucus, MLA Barkhouse.
So, Dr. Hollenhorst, during your opening statement, you said stay tuned, and it's now been almost an hour. Have I stayed tuned long enough? Because right now we have we have lung, breast, colon, and cervical cancer, and I'm just wondering, are there plans to expand the services for each of these programs in the future?
Dr. Hollenhorst.
Thank you for this question. As I've briefly mentioned, our initial cancer control strategy was really focused on stabilizing and optimizing, because we had challenges to continue providing accessible and timely care, and we have been quite successful with this so far. And looking forward into the next 5 years, what will be the priority? It became very clear that if we don't go down to the root of the cause of cancer and early detection does include screening, or patients who are symptomatic, accelerating the workup of suspected cancer, so that the time from first symptom to cancer diagnosis can be shortened. So that has been identified as the highest priority moving forward in the next few years. Also, the time is right because we have implemented digital solution in healthcare, being it the OPRR or the Oncology Transformation Project, Your Health NS and C3 and others. These are all solutions that must integrate and must be available to all Nova Scotians. This does include access to new digital and innovative solutions to reach patients, Nova Scotians, families and communities. So we envision that we work together, all our 4 screening programs, the 3 within Nova Scotia Health and the breast cancer screening program, the IWK, and work towards one entry screening and cancer prevention. So that essentially all the appointments can be made. The follow-ups that are necessary can be sent to patients. We can combine this with health and wellness education. We can launch questionnaires and patient feedback real time and response to this, and hope as such that the word spreads, because it's those who are participating, they're usually adhering. But if we stay in contact, this will be a theme. This will be continued to discuss, go out into the family, into the community, another way of engaging more people to get screened. All of our screening programs will be continuously evolving, right? And as we have heard, the dense breast and high-risk patients within breast cancer, the HPV testing within the cervical cancer program. We're also looking at innovations in lung cancer and in colorectal cancer screening. And we're also looking at new methods that are not standard of care yet, right? Looking at breathing tests, at genetic sequencing, circulating DNA, which just can be tested with a sample of blood that can be taken anywhere and everywhere. So we are involved in research and innovation and have connected with industry partners, but this is work in progress. A lot of these are not ready yet for being or becoming standard in practice, but they will. And we always try to stay on top of things and be happy to pilot some of these programs as they become available.
MLA Barkhouse.
Thank you, Chair. So then, I think maybe I heard that there will be additional screening programs for cancers not currently offered, like, I don't know, melanoma. I mean, I'm not going to put words in your mouth, but yeah.
Dr. Hollenhorst.
Yeah, so we are right now working with the Canadian Task Force for Screening and looking at the best evidence and programs that are available and that are currently being implemented nationwide or beyond. Melanoma certainly is increasing in Nova Scotia. We have high rates of melanoma diagnosis and other skin cancers. Still, there is no established skin cancer screening programs currently available or recommended. CPAC has not made it a priority yet, and I'm not aware of any active programs being underway right now. The question is, do we need a population-based screening program for melanoma or other cancers, or is there different ways of patients being able to access care, right? So we are in conversations with the Division of dermatology, and there's great strides made in new technology, AI-driven technology that actually may be helpful to be utilized in these kinds of programs.
MLA Barkhouse.
Thank you. Thank you. Well, I'm pretty sure, maybe I'm not sure, but a large percentage of the people in this room have been touched by cancer. My father passed away from actually not lung cancer, but sunburn on his lungs and brain cancer as well, and so I know it's very, he was the world to me. It was very important. It's very important to all of us. So we are aware that there are certain types of cancer present with unique challenges, if you will, when it comes to early detection. How are our screening methods determined and implemented here in Nova Scotia?
Dr. Hollenhorst. No worries.
Thank you. All our screening programs are based on best evidence, and we have close relationship with CPAC, who is helping provinces and jurisdictions along establishing screening programs. An example would be the recently implemented lung cancer screening program work that was done over several years, co-developed with First Nations and other equity-deserving populations, building the infrastructure necessary to implement such a program, the training, the teaching, not only for patients and families, but also primary care providers, implementing additional capacity in diagnostic imaging, in those who read those images, who report those images, and training patient navigation. So there's a lot of steps that we need to follow to carefully implement such a program, and then decide, how are we going to roll it out. And what we have lately used for this is research that is provided by one of our epidemiologists, Dr. Natalie St-Jacques, who is looking at 300 distinct geographic areas within Nova Scotia and looking at determinants of health and cancer risk. We have data for over 20 different kinds of cancer to determine where is cancer risk the highest. And this has usually helped us to decide where to start such a program, and then from there spread across the province. There's a lot of learnings when we start a new program, and we integrate those learnings and have our programs periodically reviewed before we decide how to further expand to really make sure all providers are best trained and best prepared family physicians, the public is informed, and the resources are in place to expand, because it would be ethically not acceptable if we offer screening and then don't have the resources in place to follow up with diagnostic tests that need to follow for any suspicious finding.
MLA Barkhouse.
So then that leads me to ask, how does Nova Scotia compare to the rest of the country in terms of access to cancer screening? And I know I heard a little bit about it in your opening statements, but...
Dr. Hollenhorst.
Yeah, so we have the 4 screening programs, as we have outlined, and these programs are accessible to all who qualified and meet the criteria for a screening program. We also, all our screening programs are navigated programs, which means that there is follow-up after being entered into the program, which can be done without a family doctor through self-referral. We try to minimize the barriers as much as possible. What we still see is that the take-up is not very high, right? Like for the colorectal screening program, we have currently 46% participation rate. We would like to have 60. For the cervical cancer screening, Rob, correct me if I'm wrong, I think we had pre-COVID 55, and now it's 48.5. We're not quite there where we were before. Breast screening, you refer to that as well. Lung screening, there's no standards existing yet, because we were the 3rd or 4th province in Canada who implemented this program. So there is no firm standards defined yet. So it's really accessible, but the participation rates are still not optimal.
MLA Barkhouse.
So I just have, Dr. Iles, I gave you a little bit of a break because you were asked so many questions, but as someone who has never gone through breast cancer, and, you know, I just want to know, I was listening intently to the conversations, and I learned quite a bit. But you had said, and I'm just kind of piggybacking off of the question about screening. You said once it's detected, once you go through this, it goes through surveillance. And can you just tell me a quick how that is for myself and anyone at home watching? I know that I've emailed a bunch of ladies to watch because these committees are quite important and informative. So,
Dr. Iles.
Thank you, MLA Barkhouse. That's a great point, and I think it's very important. In breast cancer, after you've had the diagnosis, you're no longer eligible for screening mammography. You will have to come to one of the diagnostic sites to have your mammogram done. Where we're unique compared to all the other provinces is that once you come for your first post-cancer mammogram, and those are recommended annually as long as you're in a good enough health that you would be able to have treatment if you had a recurrence or a second breast cancer, then we actually will proactively book you for your next mammogram. So you don't need to worry about your family doctor or anybody sending you a reminder. Those are proactively booked, and the appointment will be sent to you. So that's unlike all the other provinces where if you had a history of breast cancer, you have to depend on your primary care person, your oncologist, to ensure that you get annual surveillance mammography, which is what is recommended. So the difference really is screening is for asymptomatic people who've not had a diagnosis of cancer. Surveillance is once they've had a diagnosis of cancer, looking to see if they have a recurrence, if they have a second malignancy. And we do know, as MLA de Constanza has pointed out, that if you've had a history of breast cancer, your risk is somewhat higher than the average risk. That risk is very difficult to quantitate, and it's really the job of the oncologist and the breast surgeons to figure that out. That's way past my level of expertise. But what we do have currently is annual mammography surveillance, which is what is recommended.
MLA Barkhouse.
How much time do I have left?
7 minutes.
Okay,
40
I got to
seconds.
share. I have to share. There's 4 of us. I don't want to, but I will.
So you're going to tell me who?
I guess.
MLA Palmer.
MLA Palmer.
Thank you, MLA Barkhouse.
I could
Appreciate
ask questions
that.
all day.
This is a very informative and educational meeting we're having today. It's an emotional meeting as well. And I want to welcome our guests who are here today visiting us in our committee as well. There's not too many families, like my colleague has said, that aren't touched by whether it's breast cancer, any type of cancer. And one thing I'm getting from this information today and this education is that we all have a lot of work to do in getting more people to do screening and testing. And so I take that challenge on as an MLA, for sure, I can tell you. Dr. Iles, you also said that, screening is not 100% accurate. I guess we can never get 100%, but we all want to share the goal of improving outcomes and the negative effects that cancer can provide or give people. So I have a couple quick questions, and the first one, I guess, is from a rural lens. I represent a rural constituency in the Annapolis Valley, and for individuals across the country, I mean, I'm sure some of the barriers are early detection, and can often be local access to screening services in some rural areas. Can you discuss with us how some of these initiatives we've been discussing today are working to provide better access for people in rural areas who might not live close to a hospital or a clinic or someone? I'm not sure who might want to touch on that, but
Dr. Iles, I've seen you nodding. So
Yes. Well, as we've pointed out, as MLA LeBlanc pointed out, we do have a mobile screening service that is expressly designed to do that for breast cancer screening. So that's my answer for breast cancer screening. The mobile service is designed to do that, to allow access to underserved communities, underserved populations, and it is designed with the information that we have on, where people live and their ages, et cetera, to try to make sure that they have good access for breast screening. That was the reason we did the mobile.
Okay. Any?
Dr. Hollenhorst?
No, you're not chairing it, just so you know. Dr. Hollenhorst.
Thank you. Yeah, so a good example is the colorectal screening and prevention program. 186,000 kids are sent out every year, and they come to people's house where they can take the test in the privacy of their home, and they can send the test back and get the result and a call from the patient navigator if and when they qualify or should have a colonoscopy. And they will also make arrangements to receive such a colonoscopy, which usually is done within the particular zones or locations closest hospital by where possible. This only can be done by especially qualified and trained endoscopers who participate in the screening program. So this is a home kit. Hopefully with HPV testing, similar, right? We want to reach people in their homes so that they are not dependent on a family physician, and hopefully reduce that barrier of going somewhere, making an appointment, and all this kind of thing. It's just more accessible this way. With lung cancer screening, the test that's needed, so it's a self-referred program. Again, it's a navigated program where there's education about lung health given per phone, where there's a risk assessment done, and smoking cessation offered. We have the most advanced program in the country to give free nicotine replacement and the associated coaching and supports to patients and families. And again, that can be everywhere, regardless of where people are living. If they do need to have a test, a screening CT scan can be done in any hospital where a CT scanner is available. The challenge we have is not the CT scanners, because the question may be asked, why don't you put a CT scanner in a truck and drive around the province and get people their CT scan? The challenge we're having is the technicians. We can't get any technicians. Technicians are a rare commodity, and we could run our units, our machines much, much more longer and have plenty of access if there was adequate health human resources available.
MLA Palmer?
Thank you, both. You've talked about the navigation part, and I think it's maybe lends into the surveillance part afterwards too, that Dr. Iles had mentioned. And I think, Dr. Hollenhorst, in your opening statement, you might have called them nurse navigators, and then I've heard, cancer patient navigators. Are we talking about the same thing, number one? And I think that's an important role I think people need to know more about. So if you could expand a little bit about that. I know you've just touched on it here, but maybe expand on that role. And I think you might have mentioned that there's potential to expand that role going forward too.
Dr. Hollenhorst.
So navigation has been a core principle for the cancer care program for many, many years. Where this was first introduced, I think, was in breast screening years ago when Dr. Iles started the program. We also introduced navigator in patient navigators in our community oncology sites, which is a different function with different roles, but at the end of the day, it's the primary contact for a patient being diagnosed with cancer or a suspicion of cancer, to make an immediate contact with the patient and help them navigating the system, avoiding multiple conflicting appointments, providing information, getting social work involved, any kind of health support, transportation support, so on and so forth. For the navigation, for the screening programs, it's again this person one-on-one that's accessible to any Nova Scotians who is either entering a program or has an abnormal test to decide do they qualify for further diagnostic testing and how would this unfold. It's again a direct contact with the healthcare professional within a short time window to support patients along that journey. And there's other models of navigation as well. So when we talk about navigation or patient navigator or nurse navigator, it's essentially that interface between the patient, the family community, and the healthcare professional or subspecialist in oncology.
MLA Palmer with 50 seconds.
So we know that time is of the essence when it comes to maybe some kind of test that might be a little awry, and the role of those navigators. So do you feel that, like, obviously we need more? I mean, we could always use more. Do you feel that, we can move towards having more numbers that are going to be giving better service? Is that what you're...
Dr. Hollenhorst with 20 seconds.
So we have been very fortunate within our business case to stabilization cancer care that funding was provided for various patient navigators that are actively already in their jobs or are being onboarded. We're also looking at hiring liaison individuals that are situated within populations groups of equity deserve.
Sorry. So we'll be in the final round. It'll be 7 minutes, and I'll start with MLA DiCostanzo.
Thank you, Mr. Chair, and thank you to Dr. Hollenhorst. I think you just touched on my next question, and that's the shortage of technicians in the province. I think if there's anything that I can deduct from what we said today, it makes an incredible sense to do pre-screening and to catch things early. And we're dying for, or we're saying, how come there only 43% uptake or this? We want people to take. But when it comes to breast cancer, we're denying them. So to me, it does not make sense. However, it has to be a reason. And the reason is this shortage. I think Dr. Iles, her hands are tied. She would love to offer more screening and more, but her hands are tied because of the shortage that we have. I would like to ask specific questions of what we're doing for the future. I was told from my mammogram, or somebody who gave me, we're training, I believe, technologists. They're all trained as an X-ray technologist, a 4-year program, BSc, and then they specialize either in mammography, mammography, MRI, and this is extra training they take for so many months, and the pay is low. Right now, a nurse who's doing just the same 4 years are making 20 to 30,000 more. Very few technicians are going into that field because we don't pay them enough. And the incentive to take those extra is only a couple of dollars. So there's no incentive for them to specialize in new machines. We are graduating, I was told, please correct me if I'm wrong, 10. We literally need 30 today, and we want to double the population. So we need 60. What is the department doing to prepare for the future, and where are we so Dr. Iles can give us more? Who is responsible for making decisions on how many? This is radiology technologist as well as for our lab technicians. They're in the same boat. What used to take 2 weeks for the biopsy results now is taking 6 weeks. It's inhumane. And it's wrong, because my cancer, when I did the biopsy, was the size of my nail. By the time I got it was this big. I could feel it. for the 6 weeks. So what are we doing to prevent the excess weight after biopsy? How are we hiring? How are we incentivizing? Are we going abroad to bring technicians from other countries like we're doing with nurses and doctors? Who is responsible for that? And if they could answer that, please.
So, Dr. Hollenhorst, who do you want for this? Is it you?
I can.
Okay.
Sorry.
Go ahead, Dr. Hollenhorst.
I can start and maybe then have others to add to it. The health human resource crisis is not limited to Nova Scotia or Canada. It's a worldwide crisis. Right, so technologists and not only technologists but also nurses, physicians, all of these healthcare professionals are scarce. A lot of are retiring. There's a generational shift right now, and there's more and more need for subspecialization. And the models of care that are being implemented across the country also largely vary. So we're really looking at what is the right care for the right patient at the right time by the right provider, and how can we better define roles and responsibilities so that each provider can work to their full scope of practice and minimize and eliminate waste, right, where waste is present. So we have a number of different strategies that we're trying to employ. And one of them is to buy seats at the Missionary Institute in Toronto, where technologists are trained and educated, and then could be committed to a return of service while they get part or all of their tuition paid to do this work. Part of it is also to bringing them in for some practice experience, to just get to learn and get to know Nova Scotia, get to know rural areas in Nova Scotia, and perhaps find a passion and a connection to start working here. We've also implemented some sign-on bonuses, and we not always, but more often, more competitive with what other jurisdictions are offering and making available to these technicians. It's not only a matter of bringing them in, but retaining them, right? So we have to look at what makes us actually attractive for them to stay here in Nova Scotia. Yeah, we have the ocean, we have nice people, we have all these kind of things, but people have to make a living, and they want to have a career, and they want to have professional development. So we're really looking at what other supports can we wrap around these healthcare professionals to support their in fully functioning in their role that they were given and that they were trained for, right? So these are some of the initiatives, some of the supports that we put in place. The cancer care program typically has been quite successful in hiring, but we also have to be cautious because we put from other programs, right? So always have to look at the cancer, at the health system at large. If we're taking all the nurses, the acute care workers, the technicians, then other areas will run into trouble. So we are firmly integrated and collaborating with the rest of the healthcare system to try to meet that balance.
Emily DiCostanzo with 1 minute.
Sure. I didn't hear, what are our numbers now, and what is your 5-year plan or long-term plan? Just give me, what are the numbers that what is the shortage? Are we literally just graduating 10 technicians a year for Nova Scotia? Where are we graduating them here? I heard it's Toronto, so you're not graduating them here. How many seats do you see that we need right away, and how many in 5 years? And what are you doing about increasing the number for both technicians and lab technicians?
Dr. Hollenhorst.
I will not be able to answer that question because this is all part of the diagnostic networks that are outside of the governance of the cancer care program. What I can speak to is technicians in radiation oncology. We have currently a number of positions open and advertising and interviewing nationwide, and are able to give them sign-on bonus.
Sorry. MLA Lachance with 7 minutes.
Great. Thank you so much. So I'm actually going to continue on the discussion around workforce, and I think it's really important to note the important work being done by all healthcare professionals, and specifically thinking about the role of the NSGU folks in this important work. So can you clarify, so the navigator positions that you were speaking to, can you clarify how many positions of those are currently filled or vacant, I suppose, on the flip side, and who typically occupies those positions?
Dr. Hollenhorst? Or
if we maybe ask
who do you want that?
Ms. Rigby, one of our operational directors.
Sorry. Ms. Rigby. Oh, Ms. Rigby. Sorry.
Here we go. Sure. Thank you for the question. As you've mentioned, the navigation role is an important role, and it's a role that has been successful across other areas of our cancer care program and health system. And so as we launched the lung screening program, we wanted to ensure that we know already that the folks that are coming into the lung screening program are at the highest of risk, and we wanted to ensure that they had the necessary supports around them to be able to navigate and to be able to refer them to cessation counseling, tobacco, NRT, nicotine replacement therapy if necessary, and you know, so we went with this model of a nurse navigator for lung screening, and we are going to be expanding this out further. We do have screening nurses within our colon cancer screening program as well, and we're going to be basically putting in a business case to request additional resources. Right now we have no vacancies. We have both positions that we have for lung screening filled, and it is possible that as we move forward, we will need more of these resources. As the programs grow and or change, expand, we will likely need these positions in place. And they are nurses that we are hiring. And so I think it was to Helmut's point, as we, carefully try to recruit these folks, we also have to be conscious of where we're pulling them from in the system. So it's a fine balance, but we typically don't have issues with recruitment, or we haven't so far.
MLA Lachance.
And so in that case, Dr. Hollenhorst had talked about, sign-on bonuses and that sort of thing. So in the navigator roles, I guess that's because they're nurses, so they would qualify for the general nurse sign-on. And so what would you think, going back to the lung cancer screening program, so what is the timeline for expanding the cancer screening program province-wide? And based on that, what would your HR resources be?
Mrs. Rigby.
Another great question. So as was mentioned earlier, our lung screening program was launched in January of this year, and we've initiated the program with two nurse navigators, screening nurse navigators. We are currently working with our Eastern Zone partners to be able to roll out. We're targeting late fall this year. And we're also in early conversations with our Northern Zone and Western Zone partners, and looking at early in 2025 or spring of 2025, I should say, for those two.
Emily Lachance.
That's good to hear, because I know, too, that in the Eastern Zone, that's where we have the highest rates of lung cancer. And so I'm wondering, in the almost 6 months since January, since the program was launched, have folks been coming from across the province to Central Zone for screening, or has it only been limited to folks in the Central Zone?
Mrs. Rigby.
To this point, it's only been limited to the folks within Central Zone, and that's for a couple of reasons. The first is that, we definitely had to build a lot of infrastructure, create a lot of pathways and processes as we designed this program, and certainly building those off of best evidence and practice and other jurisdictions that have already rolled out lung screening. But we wanted to do it on a smaller scale, recognizing that obviously it creates a little bit of an inequity across the province initially. But we wanted to make sure that we took our time, got it right, rolled it out safely, and essentially, as the program is ready and as the zones are ready, we'll gradually bring them on board. And so, just to comment, I mean, our colon screening program has been in place for, gosh, how many years? 15? I was going to say 20 years, but it's 15 years. And that was rolled out in a similar fashion. It was rolled out by site or by, well, we weren't zones back then, but by site, and a very planned, phased implementation. And that's so we can build in opportunity to evaluate and tweak things and change things as we go, as we find areas that didn't quite work out the way we had hoped they would initially.
Emily LaChance with just over a minute.
Great. And I see someone else at the table who might want to hop in.
Okay. I assume that's Mrs. Kilroy? Kilfoil. Mrs. Kilfoil. There you go.
Thank you. Yeah, no, I just wanted to jump in on that because I think it's a great question about, did we open the lung screening program up province-wide? And one of the key things with lung screening is we recognize that it is such a devastating disease, and there was no pathway for the people who needed it most. So if you weren't attached or you had barriers, there was no way for people to get a CT scan. And so we deliberately have left it so that you have to live within the zone where it's available, because traveling is a privilege that many don't have. So we didn't want to, we wanted to make sure we knew what resources were available. We wanted to be as equitable and fair as possible. And so we do get a lot of inquiries from people who are outside the zone. And my team, takes their name, lets them know it's coming. We make referrals at that point to Tobacco-Free Nova Scotia if it's, appropriate.
Order. Sorry. Emily White, I believe. Emily White.
Thank you, Chair. So before I got a couple small questions here before I pass to Emily Young. I just want to say that thank you to the 8 of you and the hundreds, or I'm assuming maybe thousands of people that you represent that are working hard-working healthcare professionals that are helping us, as Emily Costanza has explained, a very personal story. And we recently were in Cape Breton and announced a PET CT scanner, and I think the statistic you said was 1 in 2 will have cancer to deal with, and he said it was higher in Cape Breton. So I don't know what those numbers are, but I'm sitting here and I see the folks visiting in the gallery back there, and I see you for who you are, but I see Leanne Cox back there, I see Caleb back there, I see my mom back there, I see my sister-in-law's back there. That's what I see. So it's very personal and extremely emotional topic. So I do thank Emily Costanza. I really thank you for bringing a point to this as well. The story is heartbreaking. It's wrenching, and it's something we need to learn from. Absolutely. But I do want to say that in recognizing as well what all the work you are doing. And I remember when we were campaigning, we talked about following the healthcare professionals' lead. And I'm very happy that this is the caliber of professionals we have to follow, because I'd be stumped. I have no idea where we're going to start. So, and it shouldn't be a political decision, so I appreciate all you do. So my question, earlier we talked about cervical cancer being brought at home. I think possibly 2 years, I think, was a screening test for it at home within possibly 2 years. I was kind of wanting to know if you could follow up on that and tell us maybe who would be eligible for that and how effective would it be? I think that's what we talked about earlier. I see the stump look, so I want to make sure I'm okay with that question.
I believe that was Dr. Grimshaw, if I'm not... Okay, Dr. Grimshaw.
Yeah, so we hope to roll out the self-screening as part of the transition to HPV primary screening. It'll come after the initial transition, and in terms of who it's best for, nobody knows that right now. And that's one of the things that we hope to learn. Some of that learning will come from places like BC, where they've brought it out and have made it available. And they're trying to figure out how to use it best. Is it best to put out in drugstores and let people take it? Is it best to send letters to them saying, hey, would you like to have a kit sent out to you? Or is it best to mail out a kit? It's a little different than colon screening. The kits are more expensive. The return rates I've seen in BC are around 30%. So and strangely enough in BC initially, it's lower in people that asked to have the kit sent to them than it was in people that had the kit sent out to them. We hope to use it both by securing some funding through CPAC for research to look at it in special needs groups. We know that that women, that people with cervixes and who are visible minorities are under-screened. We hope to look at using how to roll it out around the province. We've had some initial discussions with the breast program. One of the ideas when breast and cervix were originally started by the late Bob Fraser and I think the late Judy Keynes, although I hope I haven't killed her unnecessarily, so apparently I did. Judy Keynes was to have a combined mammogram screening that had a little room in the back where you get a pap test done, and that proved to be prohibitive from a space point of view. But what we'd like to do moving forward is have a way of, if a woman's coming in to have a mammogram done at a mobile clinic, to be able to have someone check her screening history for pap screening and say, hey, you haven't been screened. Would you like to have a test? Here you can do it. There's a washroom. Here's what you do. Let's go. And take advantage of those opportunities. So those are some of the things that we hope to do. We're certainly excited about self-testing. We know it can be potentially a solution for women who don't have family doctors. It can be a solution for women who sometimes in rural areas know their family doctor really well and don't particularly want to go in and have a pap test done by their next door neighbor. The little asterisk on self-screening, though, is that if you're abnormal, you'll still need to have a pap test done. So it's not an answer for women that don't want to be examined by physicians, because if it's abnormal, that goes with the territory.
MLA White.
Thank you, Chair. And the other question I want to ask is brief, is just, I'm wondering about the collaboration with the IWK and the various cancer screening treatments and programs, how that helps the youth in Nova Scotia.
Who's taking that? Okay, Dr. Hollenhorst.
So, we are one healthcare system, right? It just happens that we're in two different organizations, but we're all caring for Nova Scotians. And screening, as I said earlier, same as accelerated workup of suspected cancer, is of high priority to us. So we always have been connected with the IWK, and more recently, more frequent and more often, as we're looking at strategic directions, how to move forward. It's one of the big steps forward, hopefully, will be that one entry screening and prevention program using digital solutions that also help to teach, to educate, to advocate, but also to remind people when they are due for the next test, and so on and so forth. So a number of business cases we have actually together put forward to serve our population, regardless of what institutions, looking primarily at them. So we don't feel, and we don't want this to be a barrier, just the opposite. And I'm rather optimistic that we're going to be successful with it. Not sure if you want to add anything to it.
Dr. Iles?
Yes, I have to say that this vision for cancer care is very exciting for us, because we've always been a little program on our own. You're seeing, this is our program. You're looking at it right here. So to be able to be part of a larger vision is really important, and we're hoping that, as we've talked about, having a central intake, having a risk assessment, not just for breast cancer, for colon cancer, for lung cancer, having that central kind of point, and leveraging, as we've talked about, digital solutions for both encouraging people to come and reminding people to come back. So that's where I really see this is going to be a huge advantage for us, to be able to be collaborative with the cancer care system, which is Nova Scotia Health. We're IWK, but as Helmut has said, we work shoulder to shoulder, and our vision is better care for Nova Scotians.
Thank you, and that will be it. So this will be closing comments. I'll allow Dr. Iles to go first if you have any closing comments.
Yeah, I just.
Dr. Iles first. I'd let you go first. So.
Yes, sorry.
Well, I just want to thank everybody, particularly MLA de Costanzo, for sharing her story. It's the kind of story that breaks my heart, and I never want to hear. Running a screening program, those are the stories we don't want to hear. But we know they happen, and we would like to be able to prevent that in the future. What we need to do, as Dr. Hollenhorst has spoken about, we need to look at the evidence. We need to be able to develop a program that is properly done. We need to be able to make sure we have the infrastructure, we have the training, et cetera, et cetera. When and if the evidence becomes available, that's certainly going to be our planned approach. But it has to be done in an equitable manner as much as possible, and we do need the evidence, first of all, to start the process, and then also we need to be able to set it up in a way that it is going to work. And that's what we were talking to with the lung cancer program. You heard how that's starting in one site and then moving forward. That would be the kind of model we would follow going forward when the evidence becomes available.
Dr. Hollenhorst, thank you.
Yeah, I want to say a big thank you for inviting us today to speak to you, to listen to you. And the way I see it, it's another way of engagement, right? And what we have done all along is not talking only internally, but engaging our people, our patients, our families, our communities. And that has made us so successful up to this point. And guides us into the right direction. So everything and anything you said today, you asked today, is extremely important to us, and you represent Nova Scotians. So we take it close to our heart to develop and advance our programs, and hope we can continue having those conversations for better health care, in this case for better cancer prevention for all Nova Scotians. I also want to mention one other piece that has not been discussed at all today, and that is the primary prevention piece, health and well-being, right? More than 50% of all cancers can actually be prevented, right? Can be prevented if we vaccinate our people, if we stop smoking, reduce drinking, if we test our dwellings for radon and for arsenic, right? If we provide access, better access to care, if we exercise more healthy lifestyle choices, anything that belongs to it. But that requires accessibility of those measures, and that requires strong policy and support from government. And we just want to put forward a plea that you continue to advocate for healthier people and healthier community. It can prevent up to 50% of all cancers, and the same measures will also prevent and reduce risk for many, many other health issues that our Nova Scotians have to fight.
I'd like to thank you all for being here. I'd like to thank the audience for being very patient and putting up with 2 hours of questions. Your excuse, we are going to take a 3-minute recess before we come back. So we're in recess for 3 minutes. Order. If I can get all the MLA committee members to be in their seats, please. Okay. So, MLA Regan, I know you mentioned that you have a motion. That will be dealt with under any other business. And can you please send that to the clerk so she can share it? I assume it's not a 5-word motion. So that way everybody will see it. So the first part of the committee business is that July 2nd, 2024, letter from Derek Spinney, Nova Scotia Health, in response to request for information made at the May 14th meeting on public-private partnerships in healthcare. Is there any discussion on the correspondence? Seeing none. At the last meeting, there was a question regarding agenda setting. I reached out to Mr. Hastings, and the response I got is once an item is put there, the majority votes in the event that, for example, the PCs brought 3 forward and one of them did not get a majority vote, they would have 2 and they would be expected to bring it another one at a later time. So that would mean the NDP for 1, the Liberal for 2, just because 2 comes in. It does not mean the committee has to endorse all of them. The other question was regarding putting motions together for them. The recommendation is based on the clerk's recommendation to my right, and her preference, and any clerks, is that they are broken out, so they really should not be grouped together in future. Each one will be dealt with separately. I asked the question because it was asked. Any discussion on that? Everybody good? Okay. MLA Regan.
I move that in consideration of the information received today from the Nova Scotia Health Cancer Care Program and the NS Breast Screening Program, and in recognition of the significance and potential impacts of the Find It Early Act and Expanding HPV Testing Act, I move this committee write a letter, or the chair on our behalf write a letter, to the Minister of Health to pass this legislation.
So that motion was sent to the clerk just now, I take it? Yep. Okay, so it hasn't been received yet, so I'd like to get that to the members before we deal with it. So I don't know if you want to wait to see how.
Well, I would just say, Mr. Chair.
Yeah. Oh, sorry. MLA Regan, I recognize you.
Thank you. It is not a requirement that people have, members of the committee have, a hard copy of this or an electronic copy. It's not a difficult motion. We heard about a couple of screening programs here today that are important for women's health. We have previously talked in the legislature about the Find It Early Act. We've talked about the Expanding HPV Testing Act. So folks know what this is. It's not a complicated motion. It's just to write a letter to the Minister of Health saying that these 2 bills should be passed because these are important things for women's health. And I do believe that that it's not required that we all receive a copy of this. But, and it goes to, for our staffer, it's Judy. I'm not going to read it out loud here because I don't want folks, everybody.
Actually, the clerk's email is public. It's on the website.
I just got it. I call the question.
Well, just as you know, as being a previous chair, calling the question has no actually merit here. So, because I have a question. So I just asked the Ledge Council, and as the chair, that's why I asked for it. I have the ability to ask for it, so that's why I asked for it to be sent out. So although the member may feel that the rules don't require it, my interpretation of the rules would be totally different, as you know. So for this one, that's why I wanted it sent out. Although you say it's a simple motion, it's a lot of words. So I believe it's going out now. So we'll just, what we'll do is, I'm going to hold your motion because I'm assuming MLA LeBlanc is not asking for a motion. So I'm going to see what she wants, and as soon as she's done, they'll have enough to discuss. Emily LeBlanc.
Thanks. This falls under other business, Mr.
This is where
Chair. I just wanted to, first of all, thank the clerk for her excellent emails in advance of the meetings where we see the pronunciation of our witnesses' names and the preferred pronouns of our witnesses. I wanted to ask if we could go one step further, and that is for people who don't have an official, what do you call it, like title in front of their name, like a doctor or a, MLA, and where it's just, Trena Metcalfe. I'm wondering if we could find out if what they prefer to be referred to as, like Mrs., Ms., Mr. I'm wondering if we could do that.
She's nodding, so I'm going to allow the clerk to speak onto it.
Sure.
I recognize the clerk. You're on.
It is in the excellent email I sent you last night.
The Mrs. and Mr.?
Yeah.
Yep.
Oh, it is?
Yeah.
All right.
But would you like me to start putting it on the agenda? Like we have doctor
MLA
times.
LeBlanc. And then I'm going to close this off and go back to MLA Regan's motion.
Sure, the agenda would be helpful, or even more helpful would be just on their name cards. Okay. That would be great. Thank you.
So the clerk can deal with that. No, I assume I'll agree. Okay, so Emily Regan, we're back to your motion. Is there any discussion on the motion? MLA Young.
Thank you, Mr. Chair. With the utmost respect, like the legislature is the place to debate bills and to pass bills and pass legislation. I don't think it's for committees for 9 people to try to push bills forward. That's the whole purpose of the legislature, and just with the utmost respect.
Is there any other discussion on this? MLA LeBlanc.
Thank you, Mr. Chair. Well, I would just say that in certain jurisdictions, in many jurisdictions across Canada and at the House of Commons, there is procedure that when a bill is in the process of being debated in the legislature, it actually gets sent to committee, and the committee studies it and hears from witnesses and talks about it, and then sends it back with a recommendation. So for my money, I would support this motion, but I would just say that if our committee structure worked better, then perhaps we would have the mandate to recommend or not recommend certain bills. I wish that was the case, but it is the case in some jurisdictions.
Emily D. Costanzo.
And we are not asking to pass the bill here. We will pass it in the legislature. We just a recommendation from the committee that what we heard today, they should look at those 2 bills and pass them when time comes.
Any other discussion on this? MLA White.
Thank you, Chair. When I read this motion, it ends with, I move that the committee should write a letter to the Department of Government to pass the legislation. That's what it says, to pass legislation.
MLA D. Costanzo.
Before we go further, could we extend it by 5 minutes or 10 minutes, whatever you think is going to take us to get, we're running the clock. If we could just stay till...
I guess, let's find out. Is there any discussion on this? Okay, we're going to call the question. All in favor say aye. Aye. Contrary minded nay. Nay. Motion defeated. Any other new business? So the next meeting will be Tuesday, August 13th, 2024, from 1 to 3 p.m. Topics, links between health outcomes and lack of safe, affordable housing. Witnesses will be Department of Municipal Affairs and Housing, Department of Community Services, Department of Health and Wellness, North End Community Health Center, ADSUM for Women and Children. We are adjourned.